We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Thanks so much for being here today. I'm delighted to be introducing the speaker for today. First, I just want to acknowledge that we're gathered today on the ancestral and unceded territories of the Coast Salish peoples. And if anyone else is joining us from other territories, please do make a note in the discussion or in the chat room if you'd like, or take a moment to acknowledge where you're currently coming from. I'm really excited to introduce David Kealy. Dave and I have known each other for a very long time. He used to be my boss when we worked at a mental health clinic together, and we have since both pursued academic careers. And it's a real pleasure to be introducing him and his research today. So Dave Kealy is an associate professor in the psychotherapy program at the Department of Psychiatry at UBC. He has a background in social work and clinical leadership in public mental health services. At UBC, he conducts research on psychotherapy, personality, and identity-related mental health difficulties, including a focus on young adults and individuals with adverse childhood experiences. His work has received funding support through a Scholar Award from Michael Smith Health Research BC and grants from the Social Sciences and Humanities Research Council of Canada. Dave has published widely in academic journals and is the co-editor of the book Contemporary Psychodynamic Psychotherapy. In addition to his research, he teaches, supervises, and maintains a private practice in psychotherapy. Welcome, Dave, and we look forward to your talk.
Thanks very much, Angela, and thanks for inviting me to present today. Today I'm going to talk about identity in young adults' mental health and talk about some research that we've been doing and that's currently underway, and present some preliminary findings. So some disclosures here. I do have some private practice. I've edited a book, but I won't be speaking about those topics today. So I don't intend for there to be any bias here. And the content won't be determined by any of the funding agencies that I've been fortunate to receive support from. So today I'm going to talk about identity and some of the challenges associated with identity in young adulthood, and review some foundational research that we've done. A few selections here. I'll zip through a little bit of context, some conceptual work on identity and mental health, and I'll focus the latter part of the talk on an intervention study that we're just at the tail end of, that's specifically aimed at helping young adults who have identity-related distress. So what is identity all about? Well, we all have to answer this question for ourselves: who am I? When that question gets negotiated relatively successfully, it's something that we can more or less take for granted and move through the world sense of who we are, that lends a sense of continuity to us across time and across contexts and relationships. So it provides a sense of stability to our self-definition, our self-concept, and to the way in which other people in the world know us. We can think about identity as being comprised of our values and our beliefs, our social roles, occupational or vocational pursuits, and it's informed by our participation in social environments and the influence of important people in our lives. We don't develop an identity in a vacuum, in other words. And we can think about identity as our sense of being in the world. It's something that evolves throughout life. Although we'll be focusing on young adulthood, identity is still salient even in the latter days of one's existence. Earlier stages in our identity development, however, provide an important backdrop to subsequent experience of identity. We can think there are different perspectives and conceptual frameworks for thinking about identity, and I won't have time to go through those comprehensively today, but just to give you a flavor of that, there is a sense that we can layer a bunch of stories and narratives about ourselves that accumulate over time and that change shape in the context of our interactions and our engagements with the world. This is the perspective known as narrative identity. There's a sense of possible selves that we have. We can have a sense of possibility for who we may become in the future, or the kind of self that we may wish to avoid in the future. And I will come back to that shortly. Those of you who've taken intro psychology courses will be much more familiar with the Ericksonian model of identity and identity development. Erickson introduced this notion that we progress through stages in our identity development, and each stage has a particular task that needs to be negotiated. It's not necessarily a pass-fail, but there is a sense that we need to resolve particular identity-related struggles or issues at one stage before we can progress successfully to the next. I won't go through all of these different stages, but you may be familiar, you may have heard terms like basic trust versus mistrust in the early months of life. Young adults, who we'll talk about a lot today, are dealing with the question of identity versus confusion. Who am I? And getting a sense of how we can define ourselves as a young person, and moving into the question of, can I be intimate with others, and can I have a sense of relatedness and connectedness with others without losing my own sense of self? And with each of these stages, there are risks and perils if things don't go well. So identity is pretty critical for something that we often take for granted and don't necessarily consciously think about day to day. It's pretty important. For young people, in adolescence, early adulthood, identity is a particularly critical aspect of development. There's been a lot of work on this concept of emerging adulthood, identifying this unique developmental stage between adolescence and adulthood, for whom these questions are particularly high stakes. Questions like, who am I? What am I doing with my life? What kind of relationships or jobs or social roles are important to me and that I wish to pursue? Building on Erickson's model, Jim Marsha, who was at SFU for a long time, he developed this identity status model in which we have two dimensions to our establishment of identity or sense of who I am. We need to explore. We need to have the experience of trying different things on for size. You'll see young people experiment with different ways of behaving, different roles, different beliefs and values. But then we need to commit. We need to find some way of moving toward particular features of our identity. And so there's this negotiation between exploration and commitment. Ideally, we're doing enough of both. We're doing enough exploring, and we're doing enough committing to particular identity domains that we achieve, and we come to a relatively achieved sense of who I am and what my sense of self is. But if we don't explore enough, if we don't ever get to the stage of committing to particular ideals, values, or roles, we may end up in a state of identity diffusion, not knowing who I am, feeling a sense of being lost or empty when we think about the self. I said I'd come back to possible selves, and so possible selves refer to this representation of who I am in the future, or who I could be in the future. Conversely, there can be a sense of who I don't want to become. I don't want to be like so-and-so. So these are informed by our contemporary life experiences or our past life experiences and the meaning that we make from them. A person may have grown up with a parent who they experienced in a negative way, and they may say, look, I don't want to become like that parent. Or they may have a role model that they admired and who was very generative for them, and they would hold that person up as an ideal they may strive toward in terms of their sense of possible selves. Possible selves are important because they give us something to strive towards, something to aim at. And so consequently, they influence how we conduct ourselves now, the kinds of decisions that we make. Will those decisions lead toward a desired possible self? or might they lead us toward an undesired possible self? We can also think of identity on a continuum. If you think about Marsha's model there around exploration and commitment, if you're achieved, you're at one end of the spectrum. You've got a relatively cohesive sense of self. You feel like you're the same person, even though you navigate from one context to another. There's a sense of stability to your sense of personhood and identity. But at the other end of the spectrum, if people haven't had the opportunity to explore, people haven't had the opportunity to commit to particular values, beliefs, roles, or if people have a difficult time imagining a possible self or a relatively adaptive possible self, you might be considered to have identity diffusion, right? This is characterized by a sense of often inner emptiness, a sense of isolation, of sort of being on the outside, looking at others longingly, difficulty with intimacy and negotiating that sense of being connected, yet also a separate person. There may be a fear of losing oneself if you get close to another person. And it's difficult for people who struggle with identity diffusion to feel creative and engage in meaningful work. There's a lot of self-doubt and sometimes a rejection of social roles altogether. We think that identity-related distress and confusion among young adults may be a warning sign or a precursor to a more pronounced kind of identity diffusion that could be a risk factor for further dysfunction. And I'll talk a little bit more about that as we move into some of the research that we've done. Just a quick note in terms of identity as a mental health issue, the contemporary understanding of personality dysfunction and personality disorders is moving toward a dimensional model in which we consider the individual's self-functioning, in other words, their sense of self, their identity, their self-direction and ambition in life, and interpersonal functioning, a person's empathy or limited empathic capacity, and a person's capacity for, or lack thereof, of intimacy. And so identity, as you can see, is a core central component of our understanding of personality, functioning, and dysfunction. So hopefully you're getting a sense that focusing on identity in young adults could be an important thing to do. But in particular, young adulthood is a prime time for the emergence of mental health disorders. So there's a strong case to be made for early intervention. If we can help young adults while they are in this process of figuring out who am I, who can I become, if they're having some difficulty with that, some confusion and distress around it, we may be able to potentially help them get on a more adaptive, positive trajectory, potentially avoid some of these more negative, entrenched outcomes. As we know, personality disorder carries a lot of potential for deeply entrenched social dysfunction. It's sort of one of the hallmarks of personality dysfunction is that a lot of people who have personality disorder find it very difficult to work, have constructive relationships, and so on. And a lot of the symptomatology can both reinforce that, but also can be a byproduct of that dysfunction and impairment. So I'm going to review a little bit of some select foundational research that we've done around identity. The question that I've been focused on is the degree to which identity may transmit some of the effects of early social experience on adult psychosocial functioning and mental health. Going back to what I said about identity not coming about in a vacuum, it's really important for young people to have role models, to have supportive caregivers who can create a space and an environment that's facilitative of adaptive identity exploration and commitment and contemplation of adaptive possibilities, possible selves. We know that childhood adversity is strongly linked with psychopathology. There's a lot of work on that I won't get into today. We also know that identity is linked with psychopathology. Think about how central it is to personality dysfunction. So we think about identity as potentially a mediator between early adverse experience and the development of adult mental health challenges. And so that's some of the work that I'm going to go through here. First, I just wanted to give you a flavor of what we are doing when we're assessing identity from a self-report perspective. There are limitations to self-report assessment of identity because there can be sort of response biases. People want to make themselves look better, for example, than they actually are. But nevertheless, that's the method that we're often using. When we look at measures like self-concept and identity measure, a consolidated kind of identity, a person would answer affirmatively to an item like, I know what I believe or value. You score high on that, you're probably likely to have a pretty consolidated sense of identity. You would have a more disturbed sense of identity if you answer affirmatively to the item, I'm only complete when I'm with other people. And potentially a more profound difficulty with identity would be reflected in an affirmative response to the item, I feel lost when I think about who I am. We also look at identity distress, which is a less severe kind of identity dysfunction. Maybe I would sort of think of it as perhaps a precursor to a more disturbed or dysfunctional kind of identity problem. And that's where we ask young people, to what degree do they experience distress and upset feelings when they think about the following issues in their life? And we ask them about long-term goals, their career choices, their friendships and relationships, their identification with groups and with particular values and beliefs. So one question that we asked was, does identity commitment, a relatively clear sense of who I'm becoming and what my values and beliefs are, does that mediate the relationship between early parental support and young adults' sense of meaning in life? We recruited a community sample of young adults for this, gave them a bunch of measures that tapped into the quality of support that they received from parents early in life in terms of emotional connectedness and availability. We also asked them about their sense of dispositional optimism. To what extent do they have a positive outlook on life? We also asked about meaning in life. That was the particular outcome that we were interested in. It's good to have a sense that life is meaningful. People who have a poor sense of meaning in life are at greater risk of depression, suicidality, and so on. So we tested a mediation model, and indeed we found that along with dispositional optimism, identity commitment was in fact a significant mediator of the relationship between early parental support and young adults' sense of meaning in life. So the more people felt that parents were emotionally available and supportive of them, the greater they felt, the clearer they felt around their sense of identity, and in turn, the greater they had a sense of meaning in life. That's after controlling for general, negative emotionality. So it's a pretty clear signal there. I'm not putting the coefficients or anything with any of this work. If you're interested in that, email me and I can send that to you. So next we looked at childhood abuse, experiences of parents who are actually maltreating kids. And this is, again, a retrospective self-report. But we asked people, to what extent did they feel that parents were abusive in the way they interacted with them? And we hypothesized that would be linked with the severity of depressive symptoms, but that identity dysfunction would be a mediator, would transmit the effects of abuse into depressive symptoms in adulthood. We also put shame in this model because shame can be a precursor to depressive thoughts, and shame's a very negative affect experience that can be quite inhibiting. And we tested this model. We tested, both of these mediators, identity dysfunction and shame, in parallel and in sequence. We also introduced age as a moderator because we hypothesized that these relationships might be stronger for young people, which is this sort of like our focus is on young adults. So we wanted to see if young adults would have a stronger link between abuse and depression that was mediated by identity dysfunction. And indeed, that's what we found. We found that identity dysfunction by itself was a significant mediator between abuse and depressive symptoms, and in sequence with shame. So the more abuse a person reports, the greater degree of identity dysfunction they report, the greater degree of shame, and the greater severity of depressive symptoms, particularly for young people. In fact, it wasn't significant for adults older than 50, but the effect was a lot stronger the younger people were. So particularly for young adults, this was quite a strong effect. Also looked at suicidality and emotion dysregulation, problems that we often see in the clinic. And we recruited a clinical sample of patients from mental health clinics in Fraser Health Authority. And we asked the question, is identity diffusion, the sense of not really knowing who I am, is that associated with a greater degree of suicide ideation? And if so, does difficulty in emotion regulation, an inability to really, think about and process my emotions and handle them constructively, is that a mediator between identity diffusion and suicidality? And so indeed, we found that people who'd previously attempted suicide had higher scores on identity diffusion. We also found that identity diffusion was significantly associated with thoughts of potentially making a future suicide attempt. And indeed, we tested this mediation model. And even after controlling for general psychological distress and controlling for a previous suicide attempt, which we know is predictive of future suicidality, we found that identity diffusion had an indirect effect on anticipated future suicide attempt, and that it did so through the mediating effect of emotion regulation difficulties. So that gives you a bit of a flavor of the importance of identity, particularly for people who've had difficult early experiences in life, difficult relationships with their caregivers, and who may be at risk of negative mental health outcomes. So it kind of helps us answer this question of what gets in the way of people developing a stable, cohesive sense of identity and possible selves, and sort of following those positive adaptive trajectories. We also think, though, that trauma doesn't just sort of live by itself, that people do something with traumatic experiences, that they need to adapt to traumatic experiences. One of the ways in which they do that from a conceptual and clinical perspective is through the development of pathogenic beliefs about the self and or about the self in relation to others. So for example, a person who grows up in a home where there's not a lot of emotional attunement or warmth or love may develop the belief, I guess I don't deserve to be cared for or to feel warmth, tenderness, and protection. Or if a person grows up in a home with a parent who's extremely narcissistic and self-absorbed and doesn't sort of, contribute generously to the child's development, they may develop the belief, I must be deferential to the other person in order to have a close relationship with someone. That's how they adapt to the trauma. They figure out, in order to get along with my parent, I need to make my parent feel great all the time and put my own needs in the back seat. So there can be all kinds of pathogenic beliefs that develop from all kinds of different traumatic adverse configurations. But the general, crux of the story is that pathogenic beliefs exert a constricting effect on a person's ability to pursue adaptive identity-related goals. If you believe that you don't deserve to be cared for, that's going to play a role in the kinds of relationships that you establish. It's going to be in your mind at some level in determining whether you get involved with a person who treats you well or not, and so on and so forth. The person who develops the belief that I don't deserve to succeed in life, may unwittingly find themselves behaving in self-destructive ways, and so on. So we think that pathogenic beliefs, as a consequence of early traumatic experience, may inhibit the development of positive, adaptive, possible selves, or get in the way of a person's ability to actualize some of their imagined possible selves. So we've developed an intervention that's aimed at illuminating and modifying some of these pathogenic beliefs that young people might be constricted by. And so we want to help young adults become more aware of these pathogenic beliefs, where they come from, the function that they served, and try to reflect on them a little bit more, and hopefully create a little bit of space for them to think about these obstructing beliefs in order to help young people get on a more adaptive trajectory in terms of their identity. So expect there to be some benefits in terms of their general psychological symptoms, their self-functioning, their ability to engage in good relationships. So what's the intervention all about? It's not manualized. That's something that's different about this. It's not a brand name therapy that we've packaged and made a workbook about. Instead, we've asked therapists to engage in a conversational, supportive, expressive, counseling kind of interaction with a young adult that's based on a ground-up, individual, personalized case formulation. And we have a particular model for formulating cases. It's called the plan formulation method. It's informed by control mastery theory. Basically, what we want therapists to do is to develop a really comprehensive understanding of the client. What do they want? What are they working toward? What are the possible selves that are there in the picture for them? And what are some potential possible selves that they may not be allowing themselves to be aware of or strive toward? What are the pathogenic beliefs that might be getting in their way? We want therapists to try to use a range of interventions and even attitudes and ways of relating to the client in order to disconfirm some of the pathogenic beliefs and to promote some corrective experiences for the client. In doing so, we think that that will help young adults to engage in more reflectiveness about their life story, about the development of their pathogenic beliefs, and how they may be interfering with identity-related goals. So we have a plan formulation. All the therapists spend the first session or two thinking about and getting information to complete a formulation of who the person is and what they're working on. We review the client's goals, not only goals that the client consciously states to the therapist, but we infer potentially hidden goals that the client may not be aware of. We infer what kinds of barriers or pathogenic beliefs would be getting in the way, kinds of traumas that gave rise to those pathogenic beliefs. Then we contemplate what kind of insights or experiences in the therapy would facilitate the client's psychological work. And there's a particular feature that we've included here that we probably don't have time to get into today, but we think that clients actively seek corrective experiences in therapy, and they do so by testing their beliefs out directly in the relationship with the therapist. So that's something that we formulate and we encourage therapists to be attentive to. We offer 12 sessions, and as I say, we spend the first session or two really getting to know the client. All of the therapies are supervised, and we have research assessment pre, post, and we do a 3-month follow-up. We have some other incremental session-by-session assessment for therapy processes like the Alliance and so on. We have 2 phases. The first phase was a randomized control trial phase. We recruited 88 young adults for that. We've compared our intervention to a wait list or usual care condition, in that clients could get other services in the community. But the second phase, we added some additional participants so that we would have a sizable enough sample to look at process outcome analyses. And we're just finishing up a follow-up assessment there. So not all of the data is in, and I'm only going to be reporting on the phase 1 and only a very preliminary rough sketch analysis, because we want to do some sophisticated modeling here with our analyses. So we had 13 graduate student trainee therapists. These were non-experts, and that was a deliberate decision, because what we would ultimately like to do is to upskill non-specialist clinicians, therapists, people who don't specialize in identity or personality dysfunction, or young adults. We want to sort of keep this simple enough so that new trainees and non-specialists can learn how to work this way. And these therapists were provided with basic workshops on this plan formulation model and on much of the ideas that I've presented with so far today, as well as weekly supervision and participating in a therapist peer group. So we had 41 assigned to the wait list, 47 assigned to the intervention, and a total of 79 who completed the research data provision. And I won't get into all of the descriptives, except to note that it was compared to a lot of psychotherapy trials, it was a much more diverse sample than I've seen in the literature, in that the majority of participants were not Caucasian. And so that's something that's kind of unique. And also we had, I don't have the stats here, but we had a lot of participants who, more than one would expect, who reported sort of more than one gender identity, and a lot of more than the average sample reported non-heterosexual sexual orientation. So we were pleased to see some diversity in the sample, and we haven't analyzed that at all, but we probably will take a look at it. So we, just for these analyses I'll present today, we have some items that tap into the client's perspective of how helpful or unhelpful the therapy was for them. We look at pre-post ratings on the identity distress survey, and we look at general psychological distress, symptoms of anxiety and depression over the past month. So just to look at attrition, because one thing we want is for this to be an acceptable intervention for young people. If it had a lot of dropouts, if people said, screw this, I've got better things to do with my time, that would be a bad outcome for us. But we were pleased to see that we had pretty good retention to the study. When we look at the actual treatment condition, 44 of the 47 clients who were randomized to the treatment ended up completing all 12 sessions. So that's a 94% retention rate. Normally what you see in the literature, and we plan for this in our recruitment, you see dropout rates of 20 to 25%. And with young adults, that tends to be toward the higher end of that range. So we were really pleased that our dropout rate was so small, like 6% dropout rate's pretty good. And of the 3 who dropped out, only one of those was someone who had actually begun the therapy. So once clients started the 12 sessions, they really wanted to complete them. So how helpful did young people feel it was? So most of them scored pretty high on this item around how helpful the therapy was. 40 out of 44 said it was moderately to very helpful. How much better or worse do you think you're doing now? So 38 out of 44 scored 7 or above on a 9-point scale. So it's moderately to very much better. And the numbers were a little bit lower for to what extent have your original problems or symptoms improved, but nevertheless, on a 7-point scale, the majority scored 5 or above, indicating quite a bit to very much improved. We did a repeated measures ANOVA to look at treatment effects on general distress and identity distress, comparing to the waitlist condition. We did see a significant time by condition interaction, and the treatment was indeed associated with greater improvement in general psychological distress and identity distress. What we really want to do is take into account the fact that patients or clients were nested within therapists and do some more sophisticated modeling, multi-level modeling for that. We haven't got to that because we're still getting our data inputted. But in summary, we see that there's pretty low attrition. And so a plan formulation-based, non-manualized therapy seems to be pretty acceptable to young adults with identity distress. And a majority of clients who received this intervention rated it as moderately helpful, at least moderately helpful, and perceived their problems to improve over time. And the intervention was significantly associated with greater changes in general psychological and identity distress. But it's important to note there are some limitations. It was a pretty small sample. It's a pilot trial. Control condition is a wait list. And so that does limit some of our inferences about comparative efficacy. And as I said, we haven't looked in detail at dyadic processes. What we really want to do with this sample is to look at who does better and why, right? That's much more interesting a question than does the intervention work? I think so far we can see, yep, it works. We expected it to work, produces an effect on average, but we think that hidden within that, there are some people for whom it didn't work very well. And there are some people for whom it really worked well. And we want to learn more about that. We've got variables in there to look at that. We've recorded the sessions. We'll be able to spend years sort of like piecing together all of the sessions and figuring out what was going on there. So we think, to conclude, we think that identity is pretty important as a target for intervention, especially among young adults. And we think that one way of going about it is to engage young people in a personalized, formulation-based, conversational type of psychotherapy, rather than assigning homework and sort of getting them to do a bunch of tasks, having them feel understood by a therapist and work on their particular identity-related goals seems to have some promising effects on identity distress. We think that this is promising for the notion that we can help to upskill entry-level or non-specialist clinicians so that they can use a system or format like the plan formulation to help them with whatever other approaches that they might have in their toolkit in order to facilitate identity work with young people and potentially thereby improve mental health outcomes. And just want to acknowledge some team members, and I'm happy to take any questions.